and medical director of preventive medicine and cancer care here in Denver, Colorado. And I wanted to share with you what our practice is intending to do and some of the cutting edge advances in technology that it's utilizing for early screening and detection of various medical ailments. So, to start, I would really like to emphasize and give a little bit of background that helps to explain what we're trying to accomplish. The program was really born out of the desire and excitement around prevention and early detection, primarily for the two killers in the US population, number one and number two, that is cardiovascular disease as well as cancer. So we'll start by addressing the cancer because that's the big C word. So many people are deathly afraid of it. Currently, at best, we're able to detect maybe 20% only of cancer, be it through mammography, be it through colonoscopies or PSA and prostate markers. That is the best that we can do currently, meaning that we're missing the vast majority of cancers. And when folks present to me as a traditional oncologist, unfortunately, so many are symptomatic and have cancer that has spread and needs lots of different interventions, surgery, chemotherapy, radiation, and lifespan is very limited. Now, there's been a plethora of developments and technology over the last 5 to 10 years that is really looking to radically change the way we detect and screen for cancer. So if currently we're doing at best 20%, how can we improve those odds? Because we do know that about 50% of men in the US population will be diagnosed with an invasive cancer in their lifetime. And for women, the number is about 35 to 40%. So it's a huge, huge deal. We know that screening with certain imaging, CAT scans and MRIs, helps to improve early detection. However, we don't want to expose folks to radiation, and we do not want to image everyone unnecessarily, and insurance wouldn't cover it. So in my program, I use a specialized imaging of the abdomen and pelvis because that's where most of the concerning cancers would be found early in the course of treatment as part of the screening program. The abdominal and pelvic MRI is part of the screening program that we do annually. And that does not expose folks to radiation, and it uses different technologies to better detect early cancer lesions and concerning lesions without any injectables or any injections into the veins or bloodstream. So in addition to that, so that we know increases the early detection by about 20-fold from just physical exam and clinical evaluation. That's a decent start, and we can do better. And as a result, what I also incorporate as part and parcel of the program is more extensive blood work that has to do with inflammatory markers, with irritation in the blood vessels, with markers of cell turnover, which is measuring the rate of cell death and cell birth. The higher the rate, the more concern one would have. There would be markers related to microscopic bleeding and clotting that are part of it, as well as genetic assessment. So genetic analysis, lifestyle analysis, extensive imaging with MRIs, and extensive blood work related to inflammatory metabolism and cell turnover markers give a very, very cutting edge approach to early detection. In addition to that, we're actually able to incorporate amazing novel technologies that are called liquid biopsies. These are technologies that can be used to detect microscopic quantities of cancer DNA, be it in the sputum, in the bloodstream, in the feces, or in the urine. And we know that a combination of these technologies is able to improve cancer detection from about 20%, as I said, to, depending on the cancer, 80+%. So asymptomatic, very early, highly curable disease is much more likely to be detected early with drastically different outcomes. Switching gears to cardiovascular disease and heart attacks, similar type of approach is used. So if the MRI of the abdomen and pelvis, blood work with tumor markers, with inflammation, microscopic blood vessel damage, and bleeding and clotting markers and metabolism markers are included in the program, then they are also very useful for cardiovascular disease, and then more extensive cardiovascular imaging and assessment actually take place in the office. Let me give a little bit more in the way of background to explain why that is germane and pertinent. We know that the way we fare with cardiovascular disease, we're only able to detect more or less proactively folks who have very significant narrowing of their blood vessels. So when one gets on a treadmill or has a nuclear medicine study or has symptoms, typically we have 75+% blockage in the blood vessels that supply the heart, such that the blood supply is limited to the heart, and then we start having pain or angina or shortness of breath or funny rhythms or just not feeling well. And it is a nonsense, really, medically speaking, to say that I'm fine at one moment in time and I have disease such as a heart attack or cancer or lupus, for that matter, at a different point of time. It's really a continuum. If we start here and we're healthy, then there is a continuous progression of a development of a disease that happens until symptoms hit or until we're able to detect it in a less invasive blood test or treadmill test. So if we're talking cardiovascular disease, if I get a 50-year-old man on a treadmill and he doesn't have any symptoms and he passes the treadmill, it does not mean that that man does not have cardiovascular disease at all, no coronary artery disease. It just means that the amount of disease that's present is below the threshold of detection of technologies that are used. And unfortunately, and that's the concerning fact, about 70%, 70, of heart attacks happen in folks who have small enough plaque burden in the coronary arteries that would not be detected by standard treadmill testing, nuclear testing, and the like, and the echocardiograms, sonograms of the heart. So 70% of folks who are really at risk are typically traditionally missed, because if your screening modality is aimed to detect 70+% stenosis or blockage in your blood vessels, but the majority of events, heart attacks, strokes, and the like, happen in folks who have less than 70% blockage, then you're missing, unfortunately, the majority. Now, if you do have a significant blockage, you are at much higher risk. But if you have less, you're not disease-free. So the emphasis of the cardiovascular program that we institute is looking at where are you in this continuum? Are you if you come out of the manufacturer with blood vessels with zero blockage, zero narrowing, healthy blood vessels, and then life happens to us and we've moved towards more and more blockage as time passes, where are you currently in this condition? If this is symptoms and this is nothing, then it's much easier to reverse and go backwards, which is very much possible. When you're halfway as opposed to all the way to symptoms. So we can actually put a timeline on someone's vascular age. So how old is the person physiologically? What is their physiological age? And what is their cardiovascular age? How old are their blood vessels in the carotids? How old are their blood vessels in the groins? How old, for that matter, is their brain? We know that 60,000 miles of blood vessels are going from the neck into the brain, and that very much determines how we function, how we live our life. So the emphasis of the cardiovascular program, in addition to the markers of inflammation and irritation, is actually using sonogram technology to look at the thickness of the carotid arteries, called IMTs, and measuring how much of vulnerable plaque and thickening and calcifications one has in the blood vessels to get a better gauge for their age, for their vascular age. That's also linked to markers of inflammation and irritation that are representative of different time points. So again, if we're here plaque free, here full of plaque, different markers of inflammation and irritation appear at different points in the continuum. And doing that screening as part of the screening program actually helps folks to get a better sense as to where they are physiologically in that regard. So even if one is completely asymptomatic, the goal of the program is not to meet me as a cardiologist or an oncologist so that we have a significant problem that we're contending with. Instead, it's to be preventatively and proactively minded so that we can reverse early plaque and cardiovascular disease way before symptoms start. And we can reverse or at least pause some of the irritations that can lead to cancer formation. So to summarize, the emphasis of the program really stems out of number one and number two killers that the US population succumbs to: cardiovascular disease with heart attacks and strokes, as well as cancer. The testing incorporates extensive MRI imaging without radiation exposure of the abdomen and pelvis, looking at the cardiovascular health with imaging of the carotid arteries and arteries in the groin, femoral arteries, to get a sense of plaque burden, vulnerable and inflammatory plaque, as well as gauging the age of the cardiovascular system, and with extensive blood work that really covers you head to toe, from metabolism, organs, blood vessel irritation, tumor markers, markers of cell turnover, and endocrine health. So that objectively gives an amazing look under the hood. And then that is also combined with about 2.5, 3 hours worth of intake and interview that has to do with lifestyle, with gastrointestinal health, with gut health related to microbiome and diversity of different bacteria that live inside of us, because that is very much linked to many of the cardiovascular, cancer, and inflammatory conditions, because upwards of 80% of our immune system sits in the gut. And the more diverse the gut health is, the less likelihood of significant mortality and complications that we're seeing from number one and two killers, but incidentally, inflammatory bowel diseases, autoimmune diseases, diabetes, weight issues, endocrine health very much play into this as well. So there is a huge emphasis on gut biodiversity, on dysbiosis, and functioning of the colon and small bowel. There's a very significant emphasis as part of the program on the psycho-emotional health of a person, and I do work with my medical mafia related to specialists as well as therapists, and we often detect fascinating changes in one's brain because we can do quantitative EEGs. So these are functional brainwave and thinking abilities that we could do in the office, such that we can see how fast one's brain is, how old it is, how is one thinking right to left and back and front, how meditative or and a yogi are they, and do they have a pattern that might be reflective of depression, of anxiety, of significant PTSD or addiction, and what do we do about that? How do we de-age our brain, and how do we protect it against Alzheimer's and dementia? So a combination of psycho-emotional analysis coupled with brain imaging that we can do right here in the office, as well as gut health, as well as food sensitivity and genetic testing, gives an amazing look under the hood as to how one copes and what does it take not to just cope and survive, but actually flourish and be healthy and be well in years to come. Please reach out to us if we could be of help and service, and feel free to look at our website. It has a number of useful tools that have to do with personal cancer risk assessment. There is a free tool to look at that, as well as cardiovascular information. Should you have any questions, feel free to reach out to us at the office. We'd be happy to help.